So, uh, coronary CT angio in chronic stable coronary artery disease, when will we get it right? So, we have always believed in a dogma, and that dogma has been there for years. It has been etched in our minds that we really want to find coronary stenosis because coronary stenosis is likely to cause ischemia. We then find ischemia because we believe that it causes events and hard events. So, easiest thing that we can do is we treat stenosis. This will reduce ischemia. And once you reduce the ischemia, now how did this all come about? There are some terrific studies, landmark studies, which were conducted back in late 70s, which was started early 80s, and through to 90s. The three major artery bypass surgery, where there was a randomization which was performed with the optimal medical therapy for whatever the optimal medical therapy was available at that time. So, if the people had more than 70% stenotic lesion, and 70% came about by Professor Lance Gould's studies, where we had demonstrated that the CFR starts to significantly drop upon exertion when the stenosis is beyond 70%. And as you can see here in the left panel, that there was a significantly superior outcome with the surgical intervention or coronary bypass surgery. And this lasted for much longer than the initial presentation. And as on the right upper hand panel, you can see that the relief from angina was significantly superior in the surgically intervened cases. And also that in the, as you see the hashed bar below, that there was a significantly superior exercise capacity after the coronary artery bypass surgery. Now, there were two questions which needed to be asked. Number one, did we have optimal medical therapy at that time? We at best had started using the beta blockers, and we did not start using the aspirin. We did not have ACE inhibitors. We did not have statins. And the second important question, which I have often asked, that in absence of these statins and other plaque modifying agents, did the coronary artery lesions differ from what we see them today? And as you can see, some of the very elegant papers from one of the best pathologists of our time, Professor Michael Davies from United Kingdom, as you can see that in those days, that even if there was a stable plaque, and left lower panel is the stable plaque. I call it stable because it has a very thick fibrous cap, and this cap is not going to rupture as compared to the two right upper panel and right lower panel, which are the ones which have already resulted in an event. All the plaques, you would see that there is a large amount of the lipid core. So in absence of the So it became necessary that once we got the better therapy or more advanced therapies, we should repeat these studies. And also that now we had gotten the percutaneous coronary interventions. So the landmark study that was published in 2007, which was the Courage trial. And as you can compared to the surgical. And as you can see that the percutaneous coronary intervention with optimal medical therapy compared to the optimal medical therapy, there was no difference in the two at about 5 years time interval. And this was seen as a win for the optimal medical therapy. Indeed, it reduced the number of the PCIs in United States as well as all over the world. But was this truly a win for the optimal medical therapy? And as I have often said, that it was indeed a failure of both. percutaneous coronary intervention plus optimal medical therapy, as well as optimal medical therapy alone, up to about 20% event rate in 5 years. And if we really, I will have to switch on my light. I'm sorry. So the approximately 5% event rate every year is something which is not acceptable in 2005 or 2007. However, when these studies were being presented at that time, the FAME2 trial was brought in, and the FAME2 trial, where the functional severity of the disease was established, as you can see here, that the optimal medical therapy did much worse as compared to the percutaneous coronary intervention with optimal medical therapy, and the invasive FFR, which was used to determine the functional significance of the disease. If the FFR was normal, the PCI with optimal medical therapy, and it did as well as the ones where the FFR was normal, suggesting thereby that the optimal medical therapy did much worse than the percutaneous coronary intervention. However, when you will compare what exactly were the endpoints, and you compare the COURAGE trial with the FAME2 trial, which FAME2 trial, as you remember, was stopped at 7 months' time because they had met the endpoints. And as you would see here, that there was, in addition to the hard endpoint, that is death, myocardial infarction, there was also the need for revascularization. And if we indeed look at the need for revascularization, you will clearly see that the need for revascularization was the one that literally drove the results of the FAME2 trial. And as you can see here on the right-hand panel, on above is the death and below is the myocardial infarction there. You will see that death and myocardial infarction were no different in the optimal medical therapy group. And the only difference was in the revascularization, for revascularization. Now, how to reconcile the COURAGE trial with the FAME2 trial, as you can very clearly see, there was no difference in the hard endpoints in the COURAGE trial also. When Dr. Bill Bowden in the editorial, when he wrote it for the FAME2, he demonstrated that the outcomes about the need for revascularization were essentially similar what we had seen in FAME2, suggesting thereby that a much larger number of the people would require intervention over a period of time. At this point, we had started to believe that probably ischemia study would be the one which will settle the issue. And as you remember, that almost the same number of cases, almost the similar kind of follow-up, it again demonstrated to us that there was essentially no difference in the conservative therapy as well as the invasive therapy. However, the same group published a post-hoc analysis clearly was a significantly higher likelihood of having the spontaneous myocardial infarction in the patients treated with the conservative therapy or medical arm. So spontaneous MI rate was 5.8% in the conservative arm, and in the invasive arm, it was 2.8%. The absolute risk reduction of 3% and relative risk reduction of approximately 52%. So did ischemia demonstrate failure of revascularization to reduce MI, or indeed it was a failure of ischemia testing to guide revascularization? And we really need to settle that. FAME2 study also gave us some fabulous subsequent or the secondary analyses. Their 5-year follow-up, which is a long-term follow-up, and that was needed so as to bring it in consonance or as an equitable study, quite like the COURAGE study or the Barry 2D study or ischemia study were. As you can clearly see that even after 5 years, you'll see that the results remain the same. Myocardial infarction is borderline. the death is no different and revascularization is significantly greater that is needed. However, what was important in this particular group was that at least 50% of people, I would say actually not at least, but 49% of the people in this particular group did not die, did not have a myocardial infarction, did not need revascularization, and their relief from angina was also similar, even in the group which was treated with optimal medical therapy and abnormal FFR, clearly suggesting that the optimal medical therapy in these cases, even though the optimal medical therapy in such cases was really not optimal, but still they did quite well, suggesting thereby that we would be able to probably avoid the need for intervention in 50% more of cases. Yet another beautiful study that was published from the FAME2 data presented by Habib Samadi with Dr. DeBryan. As you can see here that they used the coronary angiograms, and these were the 3D coronary angiograms. They reconstructed them and analyzed the wall shear. As you can see, the left side and right side, that the right side is the normal wall shear, while the red is suggesting a significantly high wall shear stress. And that possibly suggests that, these are the cases where probably the plaque composition is different. Now, these are the ischemic lesions where the FFR was abnormal, but then half of them had the outcome which was significantly adverse, while in the 50% of cases it was not. And it was found that when the wall shear stress was abnormal, there was a significantly greater adverse outcomes as compared to the normal wall shear stress, suggesting thereby that the plaque composition probably has a major role to play in addition to the functional importance of the lesion. So what did we think? What do we think? And what should we think? So if you look at it, earlier we thought that all the cases which are anatomically significant lesions, they be revascularized, as was seen at the time of the surgical studies. However, when the FAME2 study came in, it suggested that one can safely avoid it in approximately 33% of cases, and the intervention may only be needed in about 66% of cases. However, if we look at the FAME2 5-year follow-up, and we look at those cases which have had the favorable outcome at 5 years, it seems that these are subjects where the lesions are not the high shear stress lesions, and they are probably the ones which could also be avoided, leaving only about 33% of cases which would indeed require revascularization. So what we thought, then we thought that now we think that it is the functional ischemia, and then in future we probably should be thinking about the plaque composition. And let me show you whether that is true or not. So what are the abnormal lesions? As we have always discussed, that these lesions have a large necrotic core. These are huge lesions. They are thin fibrous cap. In this particular case, there is a significantly large necrotic core. However, it does not impinge on the lumen so much, and there is only a moderate stenosis in this case. The two other cases, here you would see that there is a large necrotic core, huge plaque, very thin fibrous cap, and lumen is not affected at all, but it led to the death in this particular subject. And finally, you will look at the third lower panel in the right-hand side. You will see a critical lesion, critically occluded lesion, which ruptured at the thinnest side. You will see that there is a huge concentric plaque with large number of cholesterol crystals, and there is a complete occlusion of this lesion, and there is a sudden death in this particular subject. So why is it that we all have similar features, but still in some we are able to impinge on the lumen and in the others, we are not able to impinge on the lumen. And the reason is the positive remodeling, which was first demonstrated by Dr. Seymour Glagau from the University of Chicago, where he had demonstrated that up to about 40% of the cross-sectional area occupation by the necrotic core, there is no encroachment onto the lumen. And after that, there is a significantly fast or rapid, or it is with vengeance that you start to see the coronary artery occlusion. And it is obviously, it is that time that if you have a functionally significant ischemia at that time, and you have the plaques which are full of necrotic core, as you can see here in pathology, that would be the time when the lesions would become most risky at that time. So how do we identify such plaques? And this was our study with Dr. Renu Virmani, 300 coronary arteries, where we had looked at the So now, if you look at the plaque morphology in the people who had acute coronary syndrome, we found the positive remodeling and the presence of necrotic core. Greater the necrotic core, sooner was the event and greater likelihood of having an event. Then this was as seen in 1,000 cases with a 2-year follow-up. And we found that in the subjects where there was no positive remodeling and there was no necrotic core, there was less than 0.5% likelihood of having an event, giving us a hazard ratio of 45:1 as compared to those who had vulnerable plaque. However, in our largest study of 3,000 subjects for a follow-up of 10 years, we found that the large necrotic cores and positive remodeling indeed have a 10 times higher likelihood of having an event, but the non-high-risk plaques also gradually would start to develop the necrotic cores, and they may not be as benign as we found them at 2 years' time. And we also found that if there was a rapid progression of these plaques, these are about 500 cases where we had a 1 year, at a distance of 1 year, we had another CT angiogram, and we realized there that if there was a rapid plaque progression, there was a likelihood of having an event. And then we also found that since at a given time, there are 90% of the plaques are non-high-risk plaques, and even if there was a 10-fold higher likelihood of having an event, at the end of 10 years, half the events occurred from non-high-risk plaque and half the events occurred from high-risk plaque, suggesting the importance of optimal medical therapy and secondary prevention, as Professor Abdul Malik just suggested. And to end, there is a possibility, as we had seen in the Prospect 2 study, where the FFR was not abnormal, but we had huge necrotic cores. As you can see, that although there was no significant difference, the need for revascularization was more, although statistically not significant in the lesions which were not stented in this particular case. And when you talk about the statin therapy or the PCSK9 therapy, you can also see that by giving the optimal medical therapy, here the lumen is not significantly affected. You can clearly see a huge necrotic core and an abnormal FFR. However, upon maximization of statins and after 6 months of follow-up, the lumen remains the same and necrotic core has disappeared. And as we saw in the hyphen study also, not only that, there was a significant improvement in the fibrous cap thickness, suggesting thereby that there was a stabilization of a plaque. This is my last slide, and I'm most excited to present that because this is coming in JACC imaging. And as you would see here that we had approximately 700 cases, almost equally distributed in the 4 cells, where we saw these people who had their intervention based on the coronary angiogram. The invasive FFRs were not done. And these are the people where we happen to have CT angiograms done within 1 month of the coronary arteriography. And as you will see that we had the FFR by CT, which is abnormal versus FFR normal, and presence of high-risk plaques versus non-high-risk plaques. And as you can see here, that the ones in which there was both the functional importance and the pathological importance of the plaque, there was a significant difference in the outcomes. That is the 33% upon the likelihood of having an event in no revascularization group, and only 4% in the revascularization group. On the other hand, there was no difference if both FFR was normal and there was no HRP. So essentially, this would be the group which will be inappropriate for interventions. And then if you have the FFR CT, which is less than 0.8, but HRP is negative, you would see that there is no difference in the revascularization or no revascularization, suggesting thereby that this is the true courage or ischemia proposal. And could this population be safely deferred from the FAME2 indication? And finally, if you have normal FFR, but there is a high-risk plaque, again, revascularization did better compared to the non-revascularization, although it was statistically not significant, quite like the prospect 2 population. And we believe that we will be able to do equally well by very aggressive lipid lowering therapy, trying to put CT angiography to the best use in identifying these subjects. Thank you very much.